Usually when we talk about a medical procedure, there's this underlying expectation of construction.
Right.
Like, think about building a house. You put up the drywall, you paint it, and you can instantly see the new ream you've built. It's structural. It's immediate.
Exactly. But when we apply regenerative science to female intimacy, we aren't just doing construction anymore. We are actually utilizing the body's own underlying architectural blueprints to regrow the foundation from the inside out.
Which is fascinating.
Yeah.
And in this deep dive, we are looking at the clinical data behind how modern medicine is combining these two approaches.
Yeah, it's a huge shift.
Our mission today is to explore the optimal sequencing of two highly discussed procedures in the anterior vaginal wall. So we've got the G-shot, which utilizes hyaluronic acid filler, and the O-shot, which uses autologous platelet-rich plasma.
Right. And to figure this out, we're pulling from a pretty robust stack of sources today.
We really are. We've got clinical trial data from the Journal of Sexual Medicine, some comprehensive medical journal reviews, and actual clinical protocols developed by aesthetic gynecology practices.
And I think understanding how these treatments stack together gives you, the listener, a much clearer picture of where this entire field of medicine is heading.
Oh, absolutely.
Because for decades, the options available for female intimate wellness, whether you're dealing with discomfort, severe dryness, or sexual dysfunction, they were incredibly limited.
Basically just a couple of extremes, right?
Pretty much. You were essentially looking at synthetic hormone therapies, which, carry their own systemic risks, or highly invasive surgical options.
Right, there wasn't much of a middle ground.
Exactly. But these minimally invasive regenerative techniques are completely shifting the focus. It's no longer about merely treating symptoms temporarily. It's about actually restoring physiological function.
So, to understand the clinical protocols for sequencing these two treatments, we first have to look at the vastly different biological mechanisms at play here.
Yeah, that's crucial.
Let's start with the mechanical side, the HA filler used in the G-shot. I mean, we know HA is the gold standard for volume in facial aesthetics because of its hydrophilic properties.
Right, it loves water.
Right. But injecting it into the submucosal layer of the anterior vaginal wall, well, that presents a completely different mechanical challenge.
It really does. The clinical goal here is purely physical displacement. So the hyaluronic acid used in these procedures is formulated into a highly cross-linked gel.
And cross-link just means it's structurally modified to last longer, right?
Exactly. Natural hyaluronic acid breaks down the body very, very quickly. But cross-linking the molecules creates a dense, stable matrix.
Okay.
So when it's injected 1 to 2 centimeters into the anterior vaginal wall, which is the area commonly referred to as the Grafenberg spot, this cross-linked gel creates an immediate physical elevation of the tissue.
We're talking, what, like 2 to 3 millimeters?
Yeah, usually about 2 to 3 millimeters of lift.
So the mechanism is strictly volumetric. By increasing the physical prominence of that specific submucosal area, the practitioner is intentionally altering the local architecture
Exactly.
to increase physical friction and structural sensitivity during penetrative intimacy.
Right, and because it is a mechanical intervention, the structural change happens the second the injection is complete. The physical elevation is immediate.
Instant gratification.
Exactly. But even with advanced cross-linking technology, the body still metabolizes hyaluronic acid over time.
Right. It doesn't last forever.
No. The hyaluronidase enzymes in the tissue gradually break down that gel. So those volumetric results typically last anywhere from 3 to 6 months before the tissue just returns to its baseline state.
But I feel like that 3 to 6 month expiration date on the HA filler highlights its biggest limitation. It's really just a temporary architectural prop.
Yeah, that's a good way to put it.
It doesn't actually heal or alter the underlying tissue health. So to do that, the clinical protocols pivot away from synthetic volume and look toward autologous regeneration.
Which brings us to the platelet-rich plasma, or PRP, utilized in the O-shot.
Right, and this is totally different.
Completely different. The O-shot relies entirely on biology rather than physical displacement. So the process begins with a standard blood draw from the patient, usually yielding about 20 to 60 milliliters.
Just a standard draw in the office.
Yep. Then that sample is placed into a specialized centrifuge and spun at very precise speeds.
To separate everything out.
Right. This centrifugal force separates the heavy red blood cells at the bottom from the platelet-poor plasma at the top.
Leaving that middle layer.
Exactly, leaving a concentrated middle layer known as the Buffy coat. And this is where we isolate the platelet-rich plasma.
So when this highly concentrated PRP is injected back into the anterior wall in the clitoral area, those platelets are subjected to shear stress and local tissue factors.
Right, which causes them to degranulate.
Degranulate, meaning they release their contents.
Yes, they release this massive cascade of bioactive proteins and growth factors right into the tissue.
Like platelet-derived growth factor and vascular endothelial growth factor.
Epidermal growth factor, yeah. And these growth factors act as biological beacons. They actually signal the body's local mesenchymal stem cells to migrate to the area.
To start fixing things.
Exactly. They begin the process of neovascularization, which is the growth of brand new blood vessels. And furthermore, they stimulate neurogenesis.
So they're helping to regenerate and sensitize local nerve tissues.
Yes, exactly.
Okay, if I can map this out using our earlier analogy, just to make sure I've got this right.
Go for it.
So if we compare the anterior vaginal wall to a house, the HA filler in the G-shot is like adding a physical extension. You put up the drywall, you see the results instantly, but it is just structure.
Right.
The PRP in the O-shot, though, is like upgrading the electrical wiring and the plumbing inside the walls.
Oh, I love that.
It takes much longer to finish the job, and you can't necessarily see it from the outside on day one, but it fundamentally restores the underlying physiological function of the house.
That is a perfect way to look at it. And taking that plumbing and wiring comparison into the actual cellular mechanics, the PRP contains a high concentration of a protein called fibrinogen.
Fibrinogen, okay.
Yeah, and once injected into the tissue, this fibrinogen polymerizes to form a literal three-dimensional biological scaffold.
Wait, like a web inside the tissue?
Exactly like an internal microscopic web.
Yeah.
And it traps the platelets in place, preventing them from just diffusing away into the surrounding circulatory system.
Oh, wow. So this fibrin scaffold is essentially holding the platelets hostage in the exact location they are needed.
It really is. It holds them there so they can release those growth factors gradually and continuously over a 7 to 15-day period.
That's fascinating.
Right, and the sustained release forces a prolonged biological response, which explains why the clinical results of a PRP treatment can last a very long time, typically 12 to 18 months, especially when you compare it to the rapid metabolism of HA.
Okay, so looking at how these differing mechanisms perform in a clinical setting brings up this highly revealing prospective pilot study we found in the Journal of Sexual Medicine.
Yes, that study is a great benchmark.
The researchers wanted to quantify the exact differences we were talking about. So they took 16 sexually active women and split them into two distinct cohorts.
Right. One group received the cross-linked HA filler, specifically a product called Armonia.
And the other group received the autologous PRP.
Correct. And to measure the outcomes objectively, the researchers utilized the Female Sexual Function Index, or the FSFI.
Which is a highly validated, standardized clinical questionnaire, right?
Very much so. It assesses 6 specific domains of sexual function: desire, arousal, lubrication, orgasm, satisfaction, and pain.
Okay.
So the participants completed this comprehensive assessment at baseline just to establish their current physiological state, and then again precisely at the 3-month mark.
Right. And looking at those FSFI scores at 3 months, the data reveals a massive discrepancy.
It really does.
Both groups saw statistically significant improvements over their baseline, but the HA group absolutely skyrocketed. They showed a 68.1% overall improvement in their total scores.
Yeah. The data shows they spiked specifically in the desire, arousal, and orgasm domains.
But the PRP group, on the other hand, only showed a 45.7% overall improvement.
Right. But the timeline of this clinical trial is critical to interpreting that data accurately.
Okay, how so?
Well, the assessment was taken at exactly 3 months. At that specific snapshot in time, the HA filler is performing at its absolute peak.
Oh, because it's providing that immediate, tangible, volumetric effect we discussed.
Exactly. Because it instantly changed the physical architecture to increase friction, it naturally generated much higher short-term satisfaction scores. It delivered on that promise of instant structural gratification.
See, when I first read that, I looked at a 68% improvement versus a 45% improvement and immediately assumed the HA shot was simply the superior treatment.
It's an easy assumption to make.
Right. But relying on that 3-month data point is kind of a clinical trap, isn't it? Because at 3 months, the PRP group is basically still under construction.
Exactly. The cellular regenerative mechanism of PRP operates on a fundamentally different biological timeline.
It's not instantaneous.
Not at all. The human body cannot physically synthesize new type I collagen fibers or build an entirely new microvascular network overnight.
Oh.
Angiogenesis, which is the formation of new blood vessels, that takes weeks to months. The local fibroblasts need time to migrate, proliferate, and lay down new extracellular matrix.
So at the 3-month mark, the biological upgrade triggered by the PRP is still actively occurring.
Still actively occurring, yes.
And not only is it still occurring, but the PRP is addressing foundational tissue health in a way that HA fundamentally cannot.
That's the key difference right there.
Yeah, the medical reviews in our sources point out that PRP is actively reversing tissue atrophy. It is restoring natural mucosal lubrication by revitalizing the local glands, and it's increasing cellular elasticity.
And this functional restoration is absolutely vital when treating conditions like genitourinary syndrome of menopause or when working with post-cancer patients.
Why those specific demographics?
Because they often experience severe cellular starvation and thinning of the vaginal tissues due to a lack of circulating estrogen.
Oh, I see.
So mechanically lifting that tissue with HA might increase physical friction, but it does absolutely nothing to fix the underlying cellular atrophy, the chronic dryness, or the lack of blood flow.
That makes total sense.
Yeah.
So because HA provides that immediate structural peak, while PRP delivers the long-term cellular healing, the medical industry realized these treatments shouldn't be viewed as an either-or scenario.
Right.
The clinical trend highlighted in the sources has moved away from choosing one or the other and heavily toward leveraging the unique microenvironment created by combining them.
And the synergy between the two really comes down to how hyaluronic acid behaves on a molecular level in the tissue.
Okay, let's break that down.
Well, we noted earlier that HA is highly hydrophilic. It has this extraordinary capacity to bind to water, holding up to 1,000 times its own weight.
Right, that's massive.
Yeah. So when injected into the submucosal layer, it provides immediate profound hydration and turgescence, or firmness, to the surrounding tissue.
And introducing PRP into that newly hydrated, HA-rich environment completely changes the efficacy of the platelets, doesn't it?
Completely. The HA acts as an optimal supportive extracellular matrix.
Okay.
By physically expanding and hydrating the tissue, the HA literally stretches the existing cellular matrix.
Oh, interesting.
Yeah, and this mechanical stretching creates physical space, which reduces the interstitial fluid pressure. That facilitates the free entry and movement of fibroblasts right into the damaged or atrophied area.
So it basically gives the PRP's growth factors a stable, deeply hydrated scaffold to latch onto.
Exactly.
So the fibroblasts can actually migrate freely and synthesize type I collagen much more effectively than if they were just injected into a dry, collapsed tissue environment.
You hit the nail on the head.
It makes me think of agriculture again.
Oh, here we go.
Hear me out. The PRP is the nutrient-rich fertilizer and the seeds, right? It contains all the biological potential for new life.
Right, sure.
But if you throw those seeds onto soil that is totally dried out, compacted, and cracked, the roots can't penetrate and nothing is going to grow.
Exactly.
The HA acts like an advanced irrigation system, instantly hydrating, softening, and expanding the soil so the PRP seeds can actually take root and thrive.
That's a brilliant way to visualize it. And you know, the clinical demand for this irrigated soil approach is so high that it is driving tangible technological innovation.
Like what?
Well, the sources highlight specialized systems, such as the Cellular Matrix BCT-HA kit.
Oh, I read about that.
Yeah, these are designed specifically to combine a patient's autologous platelet concentrate with non-cross-linked hyaluronic acid in a single closed-system tube for simultaneous injection.
That's incredible. And the literature notes this specific combination therapy is particularly life-changing for breast cancer survivors.
It really is.
Because these women often suffer from severe vulvovaginal atrophy and dyspareunia, which is painful intercourse, due to their cancer treatments.
Right.
But because many breast cancers are hormone receptor positive, these patients are strictly contraindicated from using traditional estrogen creams to heal their tissues.
Exactly. They cannot introduce synthetic or exogenous hormones into their bodies without risking a devastating recurrence of the cancer.
Which is a terrible position to be in.
Truly. So by utilizing this synergistic combination, their own blood platelets to trigger cellular regeneration, and a natural sugar molecule like hyaluronic acid to provide the necessary hydration matrix, they achieve a completely non-hormonal physiological restoration of their tissue health.
It provides a massive improvement in quality of life without compromising their oncology protocols at all.
Exactly. It's a game changer for them.
But, okay, while those simultaneous injection kits exist, a major focus of these clinical protocols is on practitioners who administer these as distinct, separate procedures using cross-linked HA for maximum volume.
Right. That's very common.
And the literature is very clear on the optimal sequence for this dual treatment approach. You perform the autologous PRP injections,
Yeah.
O-shot first, and then you follow up with the HA filler, the G-shot, at a later stage.
Yeah, the clinical protocols define this as a deliberate reset and enhance strategy.
Reset and enhance.
Right. The biological rationale dictates that you must establish the foundation before you attempt to amplify it.
I gotta say, reading through the sources, my instinct was completely backwards on this sequence.
Really? How so?
Well, knowing that HA gives instant gratification and immediate physical volume, and knowing that PRP takes months to build new blood vessels and collagen, I assumed you would want to do the HA first.
To give them the immediate result.
Exactly. Give the patient that immediate structural result so they are happy and comfortable, and then inject the PRP to let it work in the background over the next few months.
It's a really common intuitive leap to prioritize the immediate relief, but doing the PRP first is what provides the necessary biological reset.
Yeah.
By injecting the platelet-rich plasma into the tissue first, you are stimulating tissue regeneration from the ground up. Over the following weeks and months, you increase the local blood flow, heal micro tears in the mucosa, and completely rebuild the vascular network in the anterior wall.
You are literally creating a healthier, more robust, and highly vascularized tissue foundation.
Exactly. Now, if you inject the HA first, think about what you're doing. You are pumping structural filler into atrophied, dry, or unhealthy tissue.
Oh, man.
You are mechanically elevating a structurally compromised target.
Right. Making a physical area larger doesn't improve the physiological function, the lubrication, or the sensation if that specific area lacks adequate blood flow and nerve density to begin with.
Exactly. You would just be building a large, heavy structure on a compromised foundation.
That's like putting a massive second-story addition on a house with a cracked foundation.
Yes. So the sequence is non-negotiable for optimal long-term outcomes. PRP provides the physiological restoration. It brings the tissue back to a state of healthy, vibrant function. And once that biological baseline is thriving, teeming with new nerve sensitivity and rich vascularity, then you introduce the HA filler.
And then the HA provides the structural amplification of that newly sensitized healthy tissue.
You've got it.
Reset first, enhance second. I mean, it really requires looking at the anatomy as an integrated living system that needs to be cultivated rather than just a collection of mechanical parts that can be artificially plumped up with a syringe.
Exactly. And this sequencing protocol completely changes the paradigm of how we view aesthetic gynecology.
It really does.
It is moving far beyond simple one-size-fits-all symptom management. By intelligently sequencing an autologous biological treatment to rebuild the vascular and nervous foundation, followed by an advanced structural filler to amplify those results. Modern science is offering a highly tailored cellular-level approach to female intimate health.
It is no longer just mechanical construction. It is true biological regeneration.
It really is.
And if we connect this to the broader landscape of medicine, we are witnessing a fundamental shift in how we approach aging. For decades, the medical community relied almost exclusively on synthetic hormones to fix age-related tissue decline and atrophy. But if combining our own concentrated blood platelets with a natural sugar molecule like hyaluronic acid can completely regenerate intimate tissues, what other aging or atrophy tissues in the human body could we regenerate using this exact same sequencing strategy?
It's a huge question.
Are we looking at the beginning of the end for synthetic hormone replacement altogether?
It really forces us to question the limits of our own biology. From building a house to completely redefining how we treat aging tissue, it turns out the blueprints for rebuilding the foundation were circulating inside our own blood all along.
Incredible stuff. Thanks for taking this deep dive with us today. See you next time.